Hello, tuberculosis in the new millennium. Let's complete the renal failure. Renal failure isoniazid, rifampicin, and pyrazinamide, and either eliminated almost entirely the biliary excretion or metabolized into non-toxic compounds. These drugs can therefore be given in normal dosage to patients with renal failure, patients with severe renal failure. Patients with severe renal failure should receive pyridoxine with isoniazid in order to prevent peripheral neuropathy. Streptomycin and ethambutol are excreted by the kidneys, where facilitates are available to monitor renal functions closely. Streptomycin and ethambutol may be given in reduced doses. Thiocetazone is partially excreted in the urine. However, since the margin between a therapeutic dose and a toxic dose is not narrow, patients in renal failure should not receive his drug. The safest regimen for patients with renal failure is 2HRZ/4HR, HIV infection. Generally, a TB treatment is the same for HIV infected or as for non-HIV infected TB patients, with the exception that thiocetazone is contraindicated in those who are HIV infected. Streptomycin remains a useful drug in countries able to ensure the use of sterile needles and syringes during treatment, partly due to TB itself and partly due to other HIV-related diseases are more frequent in HIV-infected patients. While the etiology, pathogenesis, and treatment for tuberculosis have been standardized over the past 50 years, new challenges continue to surface in the treatment of patients with TB. We will briefly outline the two major challenges in TB care at the beginning of the new millennium, namely the twin epidemic of TB and HIV and the emergence and spread of multi-drug resistant tuberculosis. Multi-drug resistant tuberculosis, MDR-TB. Multi-drug resistant tuberculosis, MDR-TB, is a form of tuberculosis that is resistant to two or more of the primary drugs used for the treatment of tuberculosis. Resistance to one or several forms of treatment occurs when the bacteria develops the ability to withstand antibiotic attack and relay that ability to its progeny. Since that entire strain of bacteria inherits that capacity to resist the effects of various treatments, resistance can spread from one person to another on an individual basis. However, inadequate treatment or improper use of the anti-tuberculosis medications remains an important cause of drug-resistant tuberculosis. About a third of the world's population, 2 billion, are infected the latent TB. 10% of these have the risk of developing active TB during their lifetime. The World Health Organization estimates that up to 50 million persons worldwide may be infected with MDR-TB. A recent alarming trend has been the emergence of MDR-TB worldwide, with some epicenter in Russia, China, India, Mexico, Spain, Peru, and the USA. The emergence of MDR-TB is almost always the result of inadequate chemotherapy regimens, which may be due to patient non-compliance, physician prescribing errors, lack of drug availability, and or malabsorption of a drug or drugs, particularly in AIDS patients. While historical MDR-TB spreads gradually, in the presence of HIV infection, the MDR-TB spread rapidly. Two examples will be used to illustrate the magnitude and scope of the MDR-TB epidemic. New York City. In the 1980s years, there was an epidemic of MDR TB in New York City. While New York City has 3% of the US population, it's 3,800 active TB cases in 1992, represented 14% of all TB cases in the USA. Alarmingly, 61% of isolates were MDR TB resistance or more than 2 anti-TB drugs. This epidemic could be traced to some prior public health policy decision. In 1968, $40 million were allocated for TB control and treatment. In 1978, $25 million were allocated for TB control and treatment. In 1979, $2 million were allocated for TB control and treatment. This drastic reduction led to closure of public health clinics. Outreach programs were curtailed. And in one study from a Harlem hospital, 90% of active TB cases were lost to follow-up after hospital discharge. In the 1990s years, it took over $1 billion to fix this problem with implementation of aggressive public health measures, including directly absorbed therapy, DOT. Thankfully, now we have TB under control in New York City. Penny wise, pound foolish. Russian prisons. Eastern Europe has developed into a breeding ground for MDR TB. Predisposing factors are political unrest, economic downturn, increased crime rate, spreading HIV/AIDS. Russia as a case study. There are over 1 million prisoners in Russia, of whom 10% have active infectious TB, and the rest have 10% lifetime risk of developing active TB. 30% of these prisoners have MDR TB, with a death rate 30 times higher than TB amongst the general population. Approximately 300,000 prisoners are released each year, of whom 30,000 have active TB, with at least 10% or 10,000 with MDR TB. A classic example of a public health disaster with worldwide implications of spreading Russia to New York. The role of fingerprinting. With DNA fingerprinting of TB, we can now trace the outbreaks of infections in Brooklyn, New York. A patient with W148 strain of TB was identified. This strain is a dominant strain in the toxic prison in Siberia, Russia, and is now almost always resistant to 4-drug TB regimens. Not surprisingly, this young woman in New York had immigrated from Russia. Interestingly, she had never been in Tomsk prison. Similarly, outbreaks of TB in airplanes, church choirs, etc. have been traced to the index cases with help of DNA fingerprinting. Lessons learned. MDR TB is a global public health concern in spite of multi-drug therapy, early surgical evolution in patients with a cavitary lung disease institution of dot and mandating treatment of all patients with tuberculosis. The long-term response rate defined as continuing negative sputum culture was only 56% over a median period of 57 months. To successfully combat MDR-TB, there has to be a concerted effort on a global level with a joint collaborative effort of medical professionals, public health, policymakers, politicians, and the general public. Otherwise, as Dr. Richman is in his book describes in detail, all of us are sitting on a ticking time bomb. TB and HIV, the town epidemic. World population 6 billion, TB population 2 billion. HIV infection 30 million, TB and HIV infection 15 million. 1/3 of AIDS patients worldwide have TB. 2/3 of AIDS patients in sub-Saharan Africa have TB and HIV. A lethal synergy. While HIV/AIDS has exploded over the last decade, TB has increased 20%, and today TB kills 1 out of 3 AIDS patients worldwide. These two diseases represent a deadly combination since both are more destructive together than either is alone. HIV infection is the most potent risk factor for converting latent TB into active transmissible TB, accelerating the spread of the disease, while TB bacteria help accelerate the progress of the AIDS infection in the patient. Today, TB is the leading cause of death in persons who are HIV positive. HIV, AIDS, and TB epidemic, a vicious cycle. 1 in 3 HIV infected people worldwide are co-infected with TB bacteria. TB is responsible for the death of 1 out of every 3 people with HIV/AIDS worldwide. People who are HIV positive and infected with TB are 30 times more likely to develop active TB than people who are HIV negative. The TB bacterium enhances HIV replication and might accelerate the natural progression of HIV infection. Because of the increased spread of HIV, the sub-Saharan Africa, the number of TB cases in the region will double to 4 million new cases per year soon after 205. After 25, almost half of HIV patients in sub-Saharan Africa develop active TB, whereas only 5% to 10% of individuals infected with TB and not infected with HIV develop active TB. What's needed for TB or TB control? Perhaps eradication. Magnitude of the TB infection. Today's irony is that 50 years after the introduction of effective chemotherapy, tuberculosis infects 1/3 of the world population and takes 9 months to treat. No new drugs have been introduced in 30 years, and barely 5% of the currently sick with TB can pay for treatment. Lack of buying power that has dissuaded investors for decades. TB takes a life every 15 seconds and has a global economic toll of $12 billion a year. Treating TB is in a matter of weeks, not months, will save lives and allow us to treat thousands of more patients and help promote prosperity, particularly in the developing countries. Delivering in a promise of directly absorbed therapy dots. The essential services needed to control TB based on diagnosis and treatment of infectious cases and incorporating the essential management tools were developed and packaged as a global strategy since the mid 1990 years. Countries applying dot on a wide scale have witnessed remarkable results, but dot reaches only 27% of patients. Properly applied TB chemotherapy is effective in curing infectious cases. Therapy interrupting the chain of transmission. The best prevention of TB is therefore the cure of infectious TB cases. The need to improve tools for diagnosis, treatment, and prevention of TB to make TB control more effective is well recognized. Initiative have been launched to develop new diagnostic drugs and vaccines, and the international community has started to increase investment in TB research. Despite widespread acceptance of the principles of dots, most developing countries have been unable to expand dots as rapidly as needed and have failed to achieve the global targets of detecting 70% of infectious cases and curing 85% of those detected. The main constraints to rapid expansion were identified by an ADHO Hoc Committee on the Tuberculosis Epidemic in 1998 as lack of political commitment, insufficient and ineffective use of financial resources, neglect of human resources development, poor health system organization and TB managerial capacity, poor quality and irregular supply of anti-tuberculosis drugs, and lack of information. Innovative concepts to overcome the difficulties in delivering a dot. Several innovative concepts have been introduced. One of these is the use of incentives and enablers, which may be transportation tokens or food coupons that are given to patients each time they appear at the clinic or doctor's office for treatment. Such incentives and enablers are combined with the use of directly absorbed therapy dots. Another innovation in TB treatment is the availability of FDA approved Rifter is a medication that combines three main drugs: isoniazid, rifampin, and pyrazinamide. Pyrazinamide used to treat tuberculosis into one pill. This reduces the number of pills a patient has to take daily to make it impossible for the patient to take only one of the three medications, a common path to the development of MDR-TB. Final thoughts: the promise of TB control efforts will only be fully met when healthcare workers are given the best tools that modern science can deliver. A shorter TB remission will radically improve treatment and compliance, accelerate the reach of dots, and allow more patients to be treated cost effectively. Cost saving may then be redirected to detection and treatment of patients, thus accelerating the control of the epidemic.